Thank you for joining us for the next interview in our series. This week, I spoke with Professor Michael Alvarado, breast surgical oncologist and the director of breast surgery fellowship at the University of California, San Francisco. Also, we have Anne Peled, breast surgical oncologist and reconstructive surgeon, who is the co-director of Sutter Health CPMC breast cancer program, also in San Francisco. Both Michael and Anne are at the forefront of breast cancer treatment and have popularized new techniques such as interoperative radiotherapy, preservation and restoration of nipple sensation after mastectomy, techniques such as targeted axillary dissection, and also tumor localizations with MagSeed. I wanted to speak with both of them to get the US perspective on how breast cancer treatment has evolved throughout the COVID-19 pandemic, and also to get their advice for any women who are concerned about changes to their breast and need to come in to the hospital to get checked, or for those women who need to come into the hospital to receive treatment. I want to start by saying thank you so much for joining us. It feels like a long time since we've seen each other, but hopefully that will change and get an opportunity to catch up soon. Anyway, my first question is for you, Anne. COVID-19 has presented a lot of challenges to breast cancer treatment actually throughout the world. Just wanted to understand some of the changes your practice have had to make, not only to continue treatment, but also to keep patients safe.
With COVID-19, we really had changes along the whole spectrum. So starting, I think, in terms of the screening, for the last several months, we haven't been doing any screening mammograms or screening MRIs for patients. And I think that's been, as you can imagine, very stressful for many patients, not getting their screening, worries about delays in diagnosis. And we've just recently started doing high-risk screening. And fortunately, those categories are pretty broad in terms of what they're including. So I think a lot more patients will be getting back in. Then next comes into who we've been seeing in the office. And so for us, for several months, we really weren't seeing anyone except post-op patients or patients with urgent issues in the office and doing all of our visits via telehealth. And I actually think it turns out there's a lot you can get done in telehealth consults. And even though now we've been opening up more in the Bay Area, I'm still seeing a lot of my patients via telehealth and teleconsultation.
And Michael, same question for you.
I think it's actually been beneficial to the patients and to the physicians. I think patients appreciate us doing these telemedicine visits, and they're in the comfort of their own home, and I think they feel safer for that portion. And then you can actually talk to them about what you're doing at the hospital that will make it safe for them when they eventually do come in. So I think these are some pretty good aspects of things that have changed with that COVID-19. Seeing patients virtually, we're able to do a number of things, and actually a little bit more efficient, I think. Patients that are coming from far distance, for example, we can find out what exactly they need to have done so that when they actually do come into the hospital, we can have that all set up for them. So I think that's pretty important. With regards to post-operative care, we're able to do telemedicine visits for post-operative visits as well. So I think a lot of these things are going to probably hold over for the time being and probably will be beneficial in the future to continue some of these. The concept of being able to plan everything for that patient before they actually come to the hospital is going to be a more efficient way, and I think more comfortable for the patients, especially those that come from somewhat of a distance. So I think there are some silver linings to this whole craziness, and we feel pretty comfortable that patients will be safe in the future.
The main issues that we've had in terms of the surgical side have been delays in types of reconstruction we're able to do. So we've been fairly fortunate that we've been able to continue most breast surgery cases throughout this time here in the Bay Area. I've certainly had some patients who have lower risk disease and have preferred to be put on hormone blocking therapy or just to be monitored closely in the interim and wait until it's felt safer. But I would say at this point now, almost all of my patients have come back to get their definitive surgery. And we're now able to be doing all types of reconstruction, doing prophylactic mastectomies. So I think now we're primarily over a lot of the issues from COVID in terms of the delays to getting to surgery.
You mentioned that you've made some change in the hospital to keep patients safe from contracting COVID-19. Do you think you could take us through some of those changes?
Some of the changes that we've undertaken at the hospital to keep not only ourselves safe, but especially our patients for when they come in, have to center around really the number of people that are actually allowed in the hospital, for example. So although it's difficult for patients, the patients actually are coming into the hospital by themselves without any friends or family members. Now, we know that's very difficult, both emotionally and psychologically, but we do feel that it is a safer way at this point to try to protect everyone that's coming into the hospital. So no visitors. We are screening everybody that comes into the hospital. We're trying to keep people working in one institution in terms of multiple campuses to avoid this possibility of what you might call cross contamination, for example. And really wearing masks for all people that come into the hospital, and continuing to practice, good hygiene with washing our hands at every point. And I think it's really made a big difference in terms of our hospital. We've been very fortunate not to have any cases in the cancer center, and we're trying to keep it that way as we move forward. So really trying to make that aware to patients so that they feel safe as well when they come in.
And Anne, the same question to you.
So thinking about the changes that we've implemented both in my surgery center, my private practice itself, and the hospital system I work in since COVID, I have to say it's pretty remarkable to me how quickly these systems have developed and been implemented. I actually felt pretty quickly into this, like our surgery center, our hospital was actually in many ways much safer than it would typically be during, let's say, a flu season, in terms of all the precautions we take to really protect our patients and protect our staff. So for us, we have a very detailed questionnaire that our patients, either coming into the practice or the surgery center, fill out, asking about exposure, asking about symptoms, and really trying to minimize the possibility of anyone who's asymptomatic coming into the practice. Everyone gets a temperature check and everyone wears masks. And I have to say, it feels like a lot. And when we sent out an email to our patients explaining this, I was so happy to see that we had tons of responses back about how happy they were that we were taking these precautions. We have in the logistics of how you bring in fewer people and how you socially distance, and some chairs we leave open and some we don't, and figuring all of that out has certainly been a process. But I walk into my waiting room of my practice every day and people are very respectful of each other, they're respectful of space. So I have to say, I really do think that it takes all of us doing this, but that we've really seen that people are feeling safe coming back. On the hospital side of things, we have seen one of the changes is not having visitors come in. And I find, especially for my patients, thinking about having mastectomies, staying overnight, I know that's challenging for them. And I really feel for them on the psychological part of coming in and not having someone with them as they go back. But again, I think universally people really appreciate these kind of gestures, the steps that we're taking to make sure that they're safe.
And I read in one of your tweets recently a term I'd not heard before, scanxiety. I think it refers to the patient's reluctance to want to come in and receive routine screening or routine checkups for fear of contracting COVID-19. What would your advice be to any woman out there who has experienced changes in her breast or maybe have felt a lump and the risk of coming in to get that checkup?
So with either a history of breast cancer or new breast findings, I think having any of these come up at any time is incredibly stressful, but needless to say, having them come up in the midst of a pandemic is incredibly stressful. And so we've really been doing a lot of outreach to our patients to remind them that any new breast findings, any worries, those still matter, and that we will do everything we can to have all those precautions, keep everyone safe, but those are still reasons to come in. So we have been so grateful to our breast health center, who's also been supporting these messages, making time for our patients, spreading out appointments, but staying later so that we get in more people to make sure that any women with new breast symptoms, or any people with new breast symptoms are coming in. So I think it's really important, despite the stress of COVID, to make sure that your breast health is still being taken care of.
And Michael, what are your thoughts on this?
I think there have been a lot of women who are a little bit nervous about seeking out second opinions that might take them into a part of a city that they're a little bit nervous about going to because of the virus or what they've heard about this pandemic. And I think that could be a really unfortunate problem for women if they're not able to get these second opinions. Now, there are absolutely wonderful breast surgeons in the community outside of academic centers. But even those wonderful breast surgeons should be offering second opinions to women that are being seen by general surgeons, for example. So both at our university and the exceptional breast surgeons that are in our community within the city, we need to be able to see these second opinions for these women that live farther and farther outside of these city areas. They need to be able to get these second opinions, not always because it's going to change what's going to happen, but to give them more confidence in the decisions that are being made with their own physicians. So I think that's a really important aspect of how we move forward, and we get the message out that it is safe to visit these other physicians, whether it's an academic setting or a community breast center that's within a city where there's been a number of positive tests for COVID or actual hospitalizations.
And you do a lot of reconstructions in your practice. How have they been impacted on this? Have they been delayed? Have you stopped them altogether? And are you starting to get back to normal now?
In the early period with COVID, we were finding that we were really only allowed to take care of patients who had active breast cancer. So either people who had been recently diagnosed or people who had had chemotherapy and then were ready to go on to their surgery. And as things are opening up more, we're in a position where it's really safe for people who are ready, let's say, for prophylactic mastectomies or ready for second stage of their reconstruction to come in. And what we see now in our surgery center, our hospital, is all of our patients are actually getting COVID testing. And I think that's really helped make people feel safer about coming in and allowing them to move forward with these next steps of their reconstruction. For many of my patients, having that second stage reconstruction, that touch-up fat grafting, that procedure on the other side to match whatever it might be, that really feels like they've completed their journey and allows them to move past their breast cancer. Similarly, my patients having prophylactic mastectomy, they're really ready, especially in this time of so much external anxiety, to not be thinking about mammograms and MRIs and move forward with their prophylactic mastectomies. So I feel so fortunate that now we have the testing, we have the systems in place to allow these people to safely come in for these secondary surgeries and prophylactic surgery.
With the changes that have happened to treatment throughout the pandemic, are either of you concerned that patients are going to be receiving substandard care, access to the right surgeons, second opinions, anything like that?
I worry about that all the time, but not just COVID related. Like every day with COVID, I think one of the things is, I don't know about you, Michael, but I think that obviously UCSF, we do a lot of neoadjuvant chemotherapy, whereas I see a lot of people coming in from other places where that hasn't been offered, where it so clearly should have been offered. So I think in my mind, that is one thing that in the COVID time, we've been encouraging, people who come in for that second opinion Michael's talking about, to go back and talk about neoadjuvant endocrine therapy, neoadjuvant chemotherapy, and that setting. So that's one thing. I don't know, I can talk about that. I don't know, Michael, if you've seen similar, other thoughts about.
Yeah, I mean, I agree. I think that we're always concerned that people are getting the wrong treatment. But I think there was a lot of communication across the different message boards and the ASBRS and the Society of Surgical Oncology, the American College of Surgeons, putting out all sorts of information about possibilities for treating patients in this time. So I think, if anything, it might have been a tiny bit better, or there was so much out there, because normally you're not getting blasted with, this is how you should be treating patients, and this is how you should be treating patients, and this is what so all of a sudden it's all over the place about all these different guidelines in this era. So I think it was not much different probably. But I think the biggest thing that I was worried about is what Anne was talking about, was the reconstruction options. I think the concept of, for whatever reason, taking a patient to have a mastectomy without immediate reconstruction, we didn't do that at all. And because I just think that's ridiculous. I mean, there's either the patient gets put on neoadjuvant therapy and you wait, or you put in a tissue expander in, 30 minutes, which is not a huge issue. And for people to have like cut black and white, like, nope, you can't have reconstruction. We're not doing that. Like, it's ridiculous.
Michael, how are technologies like interoperative radiotherapy helping at the moment? For those patients that can have it, it must be helpful to be sparing them the additional radiation treatment and numerous visits to the hospital after their surgery.
So in this era of COVID, we're really trying to limit the number of visits patients make. And we're also applying that within the operations and the different surgeries that we do. So things that we can do to try to decrease visits, for example, have to do with breast conservation surgery and utilizing radiation therapy afterwards. So utilizing intraoperative radiation therapy has been really important in this era of COVID. And the concept is that the patient gets their lumpectomy and has their one-time dose of radiation at the same time. That way, the patient doesn't need to come back into a facility daily, Monday through Friday, for up to 3 weeks to get 5 to 7 minutes of radiation therapy. So this is a great way to limit the number of times a patient has to actually encounter or be in the area of other patients, other healthcare workers, by offering these patients interoperative therapy, or also known as IORT. So we've really tried to champion that for these patients that fit the criteria. Other areas have to do with, again, limiting the amount of time in the operative theater, decrease the things that we do in the surgery if at all possible, if it's safe. And something that centers around that has to do with patients that are diagnosed with DCIS, or ductal carcinoma in situ. So for patients that are undergoing surgery for DCIS, the whole concept of whether or not they need a sentinel lymph node biopsy at the time of surgery, or does it need to be delayed? So something that we can do now is that they can actually get their lymph node tracing element called MagTrace, for example. That can be injected as a lymphatic mapping agent, and the patient can actually delay the sentinel node to later if they actually need it. So we're not actually spending time in the operating room looking for the sentinel node at that first surgery, because greater than 85, 90% won't need that sentinel node biopsy anyway. So it's really a great way to limit the amount of time the patient's in the operative theater with DCIS by using this concept of MagTrace and a delayed sentinel node if necessary, also known as the Sentinot way of doing things.
And what new techniques are you employing in the operating room to minimize the number of visits a patient has to have?
We're always really concerned about trying to do everything we can in that first operation to not have to come back, let's say for positive margins or needing to do an unexpected sentinel node biopsy. But in the setting of COVID, we're really even more concerned about that. And I think every procedure, we're trying to think about how can we get this patient tucked in this operation so she can move on to the next steps. So for me, I think one of the major benefits of oncoplastic surgery is being able to do a bigger lumpectomy and know that you're able to close that defect and have patients have a good aesthetic outcome, but hopefully also have the benefit of margin control. So for instance, I've been offering many of my patients where perhaps I would have thought, could we just get away, smaller scar, hidden scar lumpectomy? But if their tumors are bigger, I think, you know what, let's offer them a larger oncoplastic reconstruction. They'll heal it well, but we'll know, and we know this from data too, that we're gonna do a better job of making sure all of that tumor is out in that first stage. So I think that's been one thing that I just continue to think about in this setting and all settings. And then the other part of it is really making sure we know where the tumor is and are able to localize it in a way. And particularly with oncoplastic surgery, we need those 3D approaches to think about what does the tumor look like, how are we accessing it. And so even more than ever, wire-free alternatives really make a difference for us in terms of allowing us to take out what we need, get a sense of our margins, use that oncoplastic technique to reconstruct. And I think with these different approaches, we're able to minimize how much people come back after lumpectomies for positive margins.
Well, I just want to say thank you so much for joining us. It's been great to see you.
Yeah, good to see you.
And hopefully we get to catch up face to face very soon. But in the meantime, stay safe and thanks for everything you're doing.